Hi, everybody. I'm Rich Vogel.
Hi, and I'm Adam Doan. We're both board-certified neurophysiologists from just outside Philadelphia, Pennsylvania.
And we're also co-chairs of the NAS section on intraoperative neurophysiological monitoring.
This podcast series is about neuromonitoring and covers a wide range of educational topics aimed at optimizing patient care, decreasing cost, or maximizing OR efficiency.
Today, we're going to talk about how many surgeries are monitored in the US each year, how many of those surgeries are spine, whether utilization is increasing or decreasing, what major trends we're seeing, and what does the crystal ball tell us about the future of neuromonitoring? Let's start with the volume of surgeries monitored. Adam, what resources are available to estimate number of cases monitored in the US?
So one of the obvious ones that comes to mind is some of the larger national data sets, such as the National Inpatient Sample. So this uses ICD codes. It captures a smaller percentage, usually inpatients, when they're coded by the DRG, with the primary reason for hospitalization included. So this sort of relies on whether or not IONM is actually coded for these procedures. Probably more true for the in-house programs and not necessarily true for the outsourced programs, the outsourced companies that serve the hospitals and surgery centers. So there was a recent paper by John Ney and David Vandergoes that identified neuromonitoring in just over 110,000 procedures per year. In that year alone, I think some of the larger neuromonitoring companies probably monitor that many cases just by themselves. Granted, that looks at all monitor cases, not just spine, and NAS is obviously a spine society. So we can probably summarize that those are undersampled ways of looking at the total volume that's out there. And what I think in a couple months we are actually going to interview Dr. Ney, so he can probably elaborate on that methodology at that time. Rich, what else? What else is available?
So I think another common one is the administrative claims databases, right? And they one of the issues that we think about with them is that they tend to capture a percentage of the actual cases monitored, because what the data reflect in those databases is the number of cases that were actually reimbursed for neuromonitoring. And one common observation that we know in the neuromonitoring field is that just because you do the work doesn't mean you get paid. There's a fair amount of cases that get submitted for reimbursement but don't get reimbursed. So an example of how this can provide us with incorrect information is a recent series of papers that looked at neuromonitoring using the Pearl Diver database to estimate utilization in a variety of surgeries. Now, Pearl Diver is it houses Humana claims, and it only reports cases that were actually paid by the insurance company for neuromonitoring, which is often less than we think. So, so just as an example of how incorrect those data can be, one paper used that database and identified 2,500 cases that were ACDFs that were monitored over the course of, I think it was an 8-year span, 2,500 cases. If you look at just one large neuromonitoring company in the United States, of which there's several, they typically monitor about 20,000 ACDFs a year. So Pearl Diver found 2,500 over the course of 8 years. One company would typically monitor about 20,000 cases. So it just goes to show how inaccurate that could be. Adam, I know we also have market research reports. What comes out of those?
Probably nothing overly accurate or good, unfortunately. Yeah, because we've looked at several of those over the years, and I think we've mostly concluded that they don't really provide that much good information. Sometimes they rely on questionable sources to get some of that material. I think there's a lot less like probably money, time, research that goes into neuromonitoring market reports compared to some of like the larger revenue type companies like a medical device company. Sometimes there's crossover with EEG and evoked potential like laboratory work as well, and sometimes they even include companies that either are no longer in existence because of acquisition or other variables as well. So they're probably not the best source of material, unfortunately.
Yeah, and I guess the last source that we have, and we'll actually come to a number here, is we can look at outsourced neuromonitoring and what we know about that. Outsourced neuromonitoring, as opposed to that which is done kind of academically in-house, we think represents approximately 2/3 of all neuromonitoring in the United States. And we can look at what we know about the two largest companies out there who we know have approximately a 25% market share and collectively monitor approximately 200,000 cases a year. So we can estimate, based on the market share and what they monitor, that the total number of cases monitored in the United States is probably around 800,000 cases each year. And we also know from a variety of outsourced neuromonitoring companies, not just the largest one, that it tends to be the case that they monitor about 80% spine. So we can take that 800,000 cases and we can then make the educated guess that 80% of that, or 650,000 spine surgeries, is what gets monitored in the United States each year. At the end of the day, like I said, it's an educated guess, and there's not one really good way to estimate the number of cases that are involved with monitoring. So Adam, do we think that the number of cases monitored each year is going up or going down?
So I think it depends on who you ask, but I think there's literature that basically says it's doing both. I think there's more literature that says it's increasing than it says that it's decreasing. One of the things to keep in mind is if outsourced neuromonitoring companies don't always get coded, like as part of the DRG, maybe that's a reflection of an increased awareness of the inclusion. So is the increase secondary to more sophistication surrounding that aspect, or is it actually increasing? I think the easiest answer is that a lot of this is regional based. So we work for companies that usually have a pretty broad geographic footprint, and we see certain areas where it seems to be going up, certain areas where it's going down, and certain areas where it's plateaued, often driven by qualified, the availability of qualified people, machines, regional trends from the surgeon's perspective, and so on. Same is true if you look at this outside of America as well. So even if we're slightly increasing or even maybe a little bit plateaued domestically, I think there's definitely an increase internationally. And I know a lot of the NAS audience are from countries that aren't the United States, where neuromonitoring probably is increasing. So to bring it back to America, I think we basically follow the trends of surgery. So if more surgeries, spine surgeries are getting done, it seems like we would almost piggyback, on that. So maybe the baby boomers drive some of that increase from a neuromonitoring perspective as well. So Rich, what kind of trends are we seeing on how monitoring is used in spine surgery?
So two major trends come to mind. The first one is that we're seeing a lot of lumbar surgeries, or let me say this a different way. We're seeing motor evoked potentials used to evaluate nerve root function, and that's particularly true in lumbar surgeries. Over the past couple of years, there's been at least 10 papers that have been published demonstrating the utility of motors in lumbar surgery, particularly for detecting and obviating foot drop. And these are analogous to what we saw 10 years ago when some of the papers came out demonstrating the utility for detecting C5 palsy by monitoring motors from the deltoid. So based on this high quality research that has come out over the past 2 years, we're seeing a big uptake in the utility of monitoring motors for nerve root function, particularly in lumbar surgery. And then I think the other thing is, one of the questions that we get a lot is, is there a standard? What does everybody else do? And usually we sort of say, well, there isn't a standard. Everybody does things a little bit differently. It's the heterogeneity of neuromonitoring. But one of the things that we are seeing is in deformity surgery, really thanks to the work outside of the neurophysiology community by people like Dr. Larry Lanke and others, who are really trying to create some sort of standardization in the way we approach monitoring. So we're definitely seeing multimodality monitoring in deformity surgery, where you're using motor evoked potentials, not just for monitoring spinal cord, but also for monitoring nerve roots. You're seeing SSCPs, you're seeing EMGs, pedicle screw stimulation. All of these things are being done in terms of a comprehensive approach to monitoring these procedures. Those are the two major trends that I see right now, and those are, I think they're increasing over time. Those are the clinical trends. Adam, I know that you and I often talk about what other trends we're seeing in the profession. What comes to mind for you?
Yeah, a few things come to mind. One of them is right now, like the majority of neuromonitoring in America is outsourced. It's not run through in-house programs like at some of the larger academic centers. That's actually increasing. It's easier for an outsourced company to drive some of the efficiencies to provide staffing with because they work at more than one hospital. Usually there's a pool of clinicians in the area, so it's a little bit easier logistically to manage as an outsourced company, which is part of the reason why that's increasing. There's a desire by the neuromonitoring community to negotiate in network contracts. A large portion of the profession is out of network. That's not always because we want to be out of network. A lot of that is educating the various payers as to who we are and what we do and why we're different from the pool of, say, neurologists that they already have. Maybe they want to close their pool and we have to explain why we're different. And sometimes that takes, more than a year, sometimes several years before we actually cross the finish line. But I think that's the desire. I think that one of the trends is more engaging with surgeons. We've always lived in our own bubble, and just like we're here now as a part of NAS, trying to be a part of the team. There's huge drives for teamwork and quality and patient safety, and that benefits us as well. We want to be a part of the team. We want to engage, and we want to be able to work as a collective team. I think last but not least, the data and analytics, as the companies get bigger, you mentioned that some of the companies do monitor, around 100,000 cases a year. Being able to use that data to look at where are we being, where do we drive value? We sometimes have, like you said, if we have 20,000 ECDFs in our bank to analyze, let's use that. Let's work with the surgeons to see where there is utility and be able to drive that. I think that one of the challenges is also because the majority of the profession is outsourced, we don't always have good longitudinal outcomes. We're sort of we're limited to how the patient wakes up, and that's only obviously part of the picture. So as much as that can be a pro to have a large data set, it's also a con that we don't always have good access to the electronic health records or longer term follow-ups. Anything else, Rich? What about the future? Where are we going?
Yeah, so that's a good place to end, right? Where are we going in the future? I think probably the biggest things that are going to come out of the future of neuromonitoring are more automation and predictive analytics. I could see us getting to a place at some point in the future where you've got a monitoring system that has information fed into it about the patient, whether it's aspects of their medical history or it's real-time information about vitals and anesthetics and things like that. And then it's running tests on the nervous system, like a motor evoked potential, and instantaneously, based on all of those factors and what it knows about the patient and its ability to sort of rapidly learn about this patient, it can give you an immediate probability of postoperative paralysis in real time. That's the kind of thing that I see would be kind of the holy grail of neuromonitoring, especially for a surgeon. You don't have to wait around for information, right? You run a motor and you get instantaneously patient-specific information that's fed from that system. So we could probably talk about automation in the future to the cows come home, but that's certainly the main thing that comes to mind in terms of neuromonitoring in the future. Anything else to tack onto that, Adam?
No, I think, like you said, that's a good place to wrap up on. So thank you.
Yep, thanks for listening.